Assalamualaikum and salam sejahtera. This is the first part of abdomen lecture series. We have total of 4 abdomen lectures. In this lecture, I will explain about the anatomical organization of the abdominal walls, the major features of the diaphragm, and the structures associated with the inguinal region. I will also explain briefly regarding the clinical correlation of the anatomical structures. Abdomen is divided into 9 regions. This includes right and left hypochondriac, epigastric, umbilical, right and left lumbar, right and left iliac fossa, and hypogastric or suprapubic regions. You can also divide the abdomen into 4 quadrants. Each region is associated with the location of certain organs. For example, right hypochondriac is the region for liver and also the location for gallbladder. Right iliac fossa is where the appendix is located. You will see the locations of other organs later as I explain about the abdominal organs in the third and final parts of abdomen lecture series. Knowing the locations of each organ based on the surface anatomy helps you to come out with a differential diagnosis based on history taken from patient and physical examination. Some of the outlines of the abdominal structures can be viewed on the surface, especially in a muscular person. As you can see in this picture, some surface line marks on the abdomen are clearly visible, such as linea alba, tendinous intersection, rectus abdominis muscle, external oblique muscle, and linea semilunaris. Using surface anatomy, you can also identify the location of appendix, which is typically located underneath the McBurney's point, which is at 1/3 of the distance from the anterior superior iliac spine to the umbilicus. Surgical incision is usually made at this point for removal of an inflamed appendix. The abdomen is covered by layers of wall. This is the sagittal view of the abdominal wall sectioned at the line that I'm pointing right now. The fatty layer underneath the skin is the campus fascia. Deeper to campus fascia is a membranous layer known as scarpus fascia, followed by the abdominal muscles, namely external oblique, internal oblique, and transversus abdominis. Each muscle is lined by deep fascia. Deeper to the muscles are transversalis fascia, another fatty layer, and parietal peritoneum. If the abdomen is sectioned at this line, the components of the wall that can be seen from the sagittal view include the skin, campus fascia, scarpus fascia, rectus sheath, rectus abdominis, transversalis fascia, and parietal peritoneum. Peritoneum is a thin serous membrane. The one that lines the walls of the abdominal and pelvic cavities is called parietal peritoneum. And the peritoneum that closes the organs is known as visceral peritoneum. There are 4 muscles of anterolateral wall of abdomen, namely external oblique, internal oblique, transversus abdominis, and the one in the middle called rectus abdominis. These 3 muscles are supplied by lower 6 thoracic nerves, iliohypogastric and ilioinguinal nerves. The nerve root for iliohypogastric and ilioinguinal nerves is L1. Rectus abdominis is supplied by lower 6 thoracic nerves. Another muscle that exists in some people is known as pyramidalis muscle, which is supplied by the subcostal nerve. All of these muscles, except for pyramidalis, involve in forced expiration. Pyramidalis is thought to tense the linea alba. The most superficial of the 3 flat muscles in the anterolateral group of abdominal wall muscles is the external oblique, which is immediately deep to the superficial fascia. Its laterally placed muscle fibers pass in an inferomedial direction. its large aponeurotic component covers the anterior part of the abdominal wall to the midline. Approaching the midline, the aponeurosis is entwined, forming parts of the linea alba, which extends from the xiphoid process to the pubic symphysis. Deep to the external oblique muscle is the internal oblique muscle. This muscle is smaller and thinner than the external oblique, with most of its fibers passing in a superomedial direction. Its muscular component ends anteriorly as an aponeurosis that blends into the linea alba at the midline. Deep to the internal oblique muscle is the transversus abdominis muscle. It is called transversus abdominis because of the direction of most of its muscle fibers. It ends as an anterior aponeurosis which blends with other aponeuroses to form the linea alba at the midline. Linea alba is formed by the interlacing of aponeuroses of external oblique, internal oblique, and transversus abdominis. On each side of linea alba, we have rectus abdominis muscle with vertically directed fibers. Lastly, the pyramidalis, which is absent in small percentage of the population. Pyramidalis has been used as a landmark for linea alba intraoperatively. Rectus abdominis is a long, flat muscle and extends the length of the anterior abdominal wall. It is a paired muscle separated in the midline by the linea alba. It widens and thins as it ascends from the pubic symphysis to the costal margin. Along its course, rectus abdominis is intersected by 3 or 4 transverse fibrous bands or tendinous intersections. The other vertical muscle that can be seen here is pyramidalis. The rectus abdominis and pyramidalis muscles are enclosed by rectus sheath. Rectus sheath is formed by a layering of aponeuroses of external oblique, internal oblique, and transversus abdominis muscles. The rectus sheath completely encloses the anterior surface of the rectus abdominis. However, posterior to the rectus abdominis muscle, rectus sheath encloses only the upper 3/4 of the muscle. As no rectus sheath covers the posterior surface of the lower 1/4 of the rectus abdominis muscle, the muscle from this point inferiorly is in direct contact with the transversalis fascia. The contents of rectus sheath are rectus abdominis, superior epigastric vessels, inferior epigastric vessels, and pyramidalis muscle. The other vertical muscle is pyramidalis. The pyramidalis is a small triangular muscle which is absent in small percentage of the population. It originates from the symphysis pubis and pubic crest and inserts into the linea alba as far as 1/3 of the distance to the umbilicus. This triangular muscle lies anterior to the lower end of the rectus abdominis and becomes smaller and pointed as it ascends towards the linea alba. Although the significance of this muscle is not clear, it is thought to tense the linea alba and is used as a landmark of linea alba intraoperatively. At a point midway between the umbilicus and symphysis pubis, which corresponds to the beginning of lower 1/4 of the rectus abdominis muscle, all of the aponeuroses move anterior to the rectus muscle. From this point inferiorly, there is no posterior rectus sheath, and the rectus abdominis muscle is in direct contact with the transversalis fascia. Marking this point of transition is the arch of fibers called arcuate line. This is a cross-section of abdominal wall above arcuate line, and this one is the section below arcuate line. Above the arcuate line, both anterior and posterior rectus sheaths are present. The anterior rectus sheath is formed by the aponeurosis of the external oblique muscle and internal oblique, whereas the posterior rectus sheath is formed by the aponeurosis of the internal oblique and transversus abdominis muscles. Below the arcuate line, only the anterior rectus sheath is present, which is formed by the aponeurosis of external oblique, internal oblique, and transversus abdominis. It means below the arcuate line, rectus abdominis lies directly on the transversalis fascia. Posterior wall of the abdomen is formed by several muscles. These include part of the transverse abdominis muscle, quadratus lumborum, psoas major, psoas minor, and iliacus muscles. Quadratus lumborum and psoas muscles are supplied by the lumbar plexus or anterior branch of lumbar spinal nerves. Iliacus muscle is supplied by the femoral nerve. Quadratus lumborum flexes trunk laterally. Psoas and iliacus muscles flex thigh on trunk if the trunk is fixed, and flex trunk on thigh if the thigh is fixed. For example, when we sit up from lying position. The psoas major is a long fusiform muscle arises from the lateral surface of the bodies of 12th thoracic to 5th lumbar vertebrae, the intervertebral disc between each vertebra, and transverse processes of the lumbar vertebrae. From this origin, it courses downward across the pelvic brim, passes deep to the inguinal ligament and anterior to the hip joint capsule to form a tendon that inserts into the lesser trochanter of the femur. Associated with the psoas major muscle is the psoas minor. In this picture, psoas minor is highlighted in purple. It lies on the surface of psoas major and arises from 12th thoracic and 1st lumbar vertebrae and the intervening intervertebral disc. Its long tendon inserts into the pectineal line of the pelvic brim and the iliopubic eminence. The iliacus muscle joins the psoas major to insert via the same tendon. That's why the psoas major and iliacus are sometimes considered together as the iliopsoas muscle. Infections such as tuberculosis can form abscess in the lumbar vertebrae and can enter the fascial sheath of psoas major and spread to the thigh. Psoas or iliopsoas abscess is a collection of pus in the iliopsoas muscle compartment. The psoas muscle is situated near a number of important anatomical structures such as the vertebral bodies, abdominal aorta, sigmoid colon, appendix, hip joint, and iliac lymph nodes. Infection may spread directly between these structures and the psoas muscle. Iliopsoas sign is the terminology used to describe the iliopsoas pain due to the inflammation of structures adjacent to the psoas major. Ligaments and tendon are also considered as parts of significant abdominal structures. These include inguinal ligament, lacunar ligament, pectineal ligament, and conjoint tendon. The lower border of the external oblique aponeurosis forms the inguinal ligament on each side. It passes between the anterior superior iliac spine and the pubic tubercle. It plays an important role in the formation of the inguinal canal. Lacunar ligament is a crescent-shaped extension of fibers at the medial end of the inguinal ligament. It is reflected backward and laterally and is attached to the pectineal line of the pubis. Its apex corresponds to the pubic tubercle. Additional fibers extend from the lacunar ligament along the pectineal line of the pubic bone to form the pectineal ligament. Another significant structure of abdomen is the conjoint tendon. This tendon is the combined insertion of the aponeurosis of internal oblique and transversus abdominis muscles. Conjoint tendon is located posterior to the superficial inguinal ring and forms the medial part of the posterior wall of the inguinal canal. The position of the conjoint tendon provides additional support to a potential point of weakness in the anterior abdominal wall. In other words, it strengthens the middle part of the posterior wall of the inguinal canal. A weakening of the conjoint tendon can precipitate a direct inguinal hernia. This is another picture showing the inguinal ligament, lacunar ligament, and conjoint tendon. Numerous blood vessels supply the anterolateral abdominal wall. Superficially, the superior part of the wall is supplied by branches of the musculophrenic artery, a terminal branch of the internal thoracic artery. The inferior part of the wall is supplied by the medially placed superficial epigastric artery and the laterally placed superficial circumflex iliac artery. Both are branches of the femoral artery. At the deeper level, the superior part of the wall is supplied by the superior epigastric artery, which is a terminal branch of the internal thoracic artery. The lateral part of the wall is supplied by branches of the 10th and 11th intercostal arteries and the subcostal artery. And the inferior part of the wall is supplied by the medially placed inferior epigastric artery and the laterally placed deep circumflex iliac artery. Both are branches of the external iliac artery. The superior and inferior epigastric arteries both enter the rectus sheath. They are posterior to the rectus abdominis muscle throughout their course and anastomose with each other. Deep veins of similar names follow the arteries and are responsible for venous drainage. As shown in this picture, the inferior epigastric vein drains deoxygenated blood into external iliac vein, which then drains the blood into common iliac vein and inferior vena cava. Superior epigastric and musculophrenic veins drain into internal thoracic vein, then subclavian vein, which drains the blood into brachiocephalic vein and superior vena cava. Some veins are different in drainage. These include the 10th and 11th intercostal veins and subcostal vein that drain to the azygous and hemiazygous system. For superficial venous drainage above the transumbilical plane, the deoxygenated blood is drained into thoracoepigastric vein, then into the lateral thoracic vein. The lateral thoracic vein joins the axillary vein, which continues with the subclavian and brachiocephalic veins and eventually drains into the superior vena cava. Below the transumbilical plane, deoxygenated blood is drained by the superficial epigastric and superficial circumflex iliac veins. These vessels drain via the great saphenous vein into the femoral, external iliac, and common iliac veins, and eventually into the inferior vena cava. Superficial epigastric vein also drains into the portal vein through the paraumbilical veins. Through this venous linkage to both the inferior vena cava and portal vein, a portocaval anastomosis is established. Occlusion of the portal vein may activate this collateral venous circulation, producing distension of the paraumbilical veins. Prominent dilation of these veins is called caput medusa. The name is given after a Greek mythological character, Medusa, whose head was covered with snakes that resembles the radial pattern of varicose paraumbilical veins around the umbilicus. The thoracoepigastric vein drains the middle portion of the anterolateral abdomen and connects the superficial epigastric and superficial circumflex iliac veins to the lateral thoracic vein. Through these venous connections, the lateral thoracic vein forms a venous link for cava-caval anastomosis. Occlusion of the inferior vena cava is most likely to activate this collateral venous circulation, producing dilation of the thoracoepigastric, the lateral thoracic, and the tributaries of the superficial circumflex iliac and the superficial epigastric veins, giving this appearance of dilated veins. Four or five pairs of lumbar arteries arise from the abdominal aorta and supply the lumbar vertebrae, back muscles, and posterior abdominal wall. They are also known as parietal branches of abdominal aorta. The visceral branches are the arteries that supply the abdominal organs, which will be explained in the other part of abdomen lecture series. The veins of the posterior abdominal wall are tributaries of the inferior vena cava, except for the left gonadal vein, which enters the left renal vein instead of entering the inferior vena cava. Superficial lymphatics above the umbilicus pass in a superior direction to the axillary nodes, while drainage below the umbilicus passes in an inferior direction to the superficial inguinal nodes. Lymph from superficial inguinal nodes is drained into deep inguinal lymph nodes and then into external iliac lymph nodes. For deeper lymphatic drainage, lymph from the external iliac lymph nodes is drained by the common iliac nodes, which then drains the lymph to the lumbar lymph nodes or para-aortic nodes. These nodes lie on the posterior abdominal wall along the abdominal aorta. Efferent vessels of lumbar nodes drain the lymph into lumbar lymph trunks. Right and left lumbar lymph trunks and intestinal lymph trunks unite at the cisterna chyli, which drains the lymph into thoracic duct. I will explain about the efferent vessels that drain into intestinal lymph trunk in other parts of abdomen lecture series. The lymph from the thoracic duct then return back to the blood circulation at the junction between the left subclavian and left internal jugular veins. Lymph from the deeper structures of the anterior abdominal wall above the level of umbilicus follows the deep arteries back to the parasternal nodes along the internal thoracic artery. From parasternal nodes, the lymph is drained into the bronchomediastinal trunk. Right bronchomediastinal trunk drains lymph into the right lymphatic duct, and the lymph from the left bronchomediastinal trunk drains into the thoracic duct. The abdominal wall is innervated by the ventral rami of the lower 6 thoracic spinal nerves T7 to T12. T7 to T11 are the intercostal nerves, and T12 is the subcostal nerve. These thoracic nerves are distributed to the intercostal muscles, anterolateral abdominal muscles, skin of the thoracic and abdominal walls, pleura, and parietal peritoneum. The anterolateral abdomen also receives nerve fibers from the iliohypogastric and ilioinguinal nerves. Both nerves arise from lumbar spinal nerve 1 or L1. The anterolateral abdominal wall is supplied segmentally by the 7th to 11th intercostal nerves, subcostal nerve, and L1. The intercostal nerves cross the costal margin obliquely to run in the neurovascular plane of the anterior abdominal wall between the internal oblique and transversus abdominis muscles. The nerves supply these muscles and divide into lateral and anterior branches. The lateral branches pierce the flat abdominal muscles in the mid-axillary line to reach the skin, while the anterior branches run medially before piercing the rectus sheath and emerge anteriorly to reach the skin. The subcostal nerve runs along the border of the 12th rib until it passes into the abdominal wall and runs in between the transverse abdominis and internal oblique. The subcostal nerve innervates transversus abdominis, internal oblique, the inferior portion of the external oblique, the skin, superior region to the iliac crest, and inferior to the umbilicus. The subcostal nerve also supplies the pyramidalis. Cutaneous innervation of the anterior abdominal wall by the 7th to 11th intercostal nerves, subcostal nerve, and L1 is represented by a series of oblique band-shaped dermatomes. The dermatome corresponding to the 10th intercostal nerve is at the level of the umbilicus. The 11th intercostal and subcostal nerves supply strips of skin below the umbilical level, while the iliohypogastric nerve and the ilioinguinal nerve supply a strip of skin immediately above the inguinal ligament and pubic symphysis. Since thoracoabdominal nerves also convey sensation from the costal and peripheral diaphragmatic pleura, pleural inflammation can also produce pain felt in the abdominal wall. As I mentioned in previous slide, the anterolateral abdomen also receives nerve fibers from the iliohypogastric and ilioinguinal nerves. Both nerves arise from lumbar spinal nerve 1 or L1. The iliohypogastric is the continuation of the superior branch of the anterior ramus of L1. It runs between transversus abdominis and internal oblique muscles, then emerges once again through the external oblique aponeurosis. The iliohypogastric innervates the transversus abdominis and internal oblique muscles, then supplies the skin of the lower part of the anterior abdominal wall. The ilioinguinal nerve extends from the inferior branch of the anterior ramus of L1. The ilioinguinal nerve runs parallel to and below the iliohypogastric nerve and has a slightly more oblique course as it traverses the anterior surface of the quadratus lumborum muscle. At the anterior end of the iliac crest, the ilioinguinal nerve pierces the transversus abdominis and internal oblique muscles to enter the inguinal canal from the side, not through the deep ring. The nerve continues in the inguinal canal and exits at the superficial inguinal ring to become subcutaneous. It supplies the skin of the groin and the scrotum or labium majus. Next, let's look at the nerves of the posterior abdominal wall. These nerves derived from the lumbar plexus, a complex joining and rebranching of the anterior primary rami of the 12th thoracic to the 5th lumbar segment. The nerves that arise from the lumbar plexus emerge from beneath psoas major or through it. Here is the subcostal nerve, which comes from T12, the iliohypogastric nerve, and ilioinguinal nerve. This is lateral cutaneous nerve of the thigh and the genital femoral nerve. Here are two major nerves of the lower extremity, the femoral nerve, that emerge lateral to psoas major, and another one is the obturator nerve, emerging medial to it. The femoral nerve runs alongside psoas major and passes beneath the inguinal ligament just lateral to the femoral artery. The obturator nerve runs just below the pelvic brim and enters the obturator canal. You can refer to the lower limb lecture for the structures and regions supplied by these nerves. Diaphragm is the fibromuscular structure that separates the abdominal cavity from the thoracic cavity. It has three parts based on the attachment to the sternum, costal cartilage, and lumbar vertebra. The sensory nerve supply to the center of diaphragm is by the phrenic nerve, which originates from C3 to C5 spinal nerves. The sensory nerve supply of peripheral diaphragm is by the lower 6 intercostal nerves. Motor innervation of the whole diaphragm is supplied by the right and left phrenic nerves. There are a number of openings in the diaphragm through which structures pass between the thorax and abdomen, but here I will only focus on the three large openings or hiatus, namely the aortic, the esophageal, and the caval openings. The caval opening passes through the central tendon of the diaphragm. It contains the inferior vena cava and some branches of the right phrenic nerve. Second opening is the esophageal hiatus, which is situated in the posterior part of the diaphragm. It is located slightly left of the central tendon through the muscular sling of the right cruce of the diaphragm. The main structures that pass through the esophageal hiatus are the esophagus and vagal trunks. The third opening is the aortic hiatus or aortic opening, which is located in the posterior part of the diaphragm between the left and right cruce. The main structures that pass through this hiatus are the aorta and the thoracic duct. Congenital diaphragmatic hernia occurs when the diaphragm that separates the chest from the abdomen fails to close during prenatal development. This opening allows contents of the abdomen, such as stomach, intestine, or other organs, to migrate into the chest, impacting the growth and development of the lungs. Congenital diaphragmatic hernia is one of the most common major congenital anomalies. It can occur on the left or right side, or rarely on both sides. In this picture, you can see the diaphragm, which is a sheet of flat muscle that separates the heart and lungs from the abdominal cavity. In congenital diaphragmatic hernia, a hole in the diaphragm allows abdominal organs to move into the chest and restrict lung development. The inguinal region, also known as the groin, is the area at the lower portion of the anterior abdominal wall, with the thigh inferiorly, the pubic tubercle medially, and the anterior superior iliac spine superolaterally. It is the location for inguinal canal. I have listed here some of the anatomical landmarks related to the inguinal region and the inguinal canal that you have to understand and able to describe at the end of this lecture. Inguinal canal is a short passage located at the lower part of the abdomen over the inguinal region. It extends in the downward and medial direction parallel to and above the inguinal ligament. Inguinal canal begins at the deep inguinal ring and ends at the superficial inguinal ring. The deep or internal inguinal ring is a funnel-shaped opening in the transversalis fascia and is located just above the midpoint of the inguinal ligament. Midpoint of the inguinal ligament is the point midway between the anterior superior iliac spine and the pubic tubercle. It is used as the landmark for deep inguinal ring. Deep inguinal ring is located above the inguinal ligament and lateral to the inferior epigastric vessels, whereas the mid-inguinal point is the point midway between the anterior superior iliac spine and the pubic symphysis. Mid-inguinal point is the landmark for femoral artery. Superficial inguinal ring is the end of the inguinal canal and is superior to the pubic tubercle. It is a triangular opening in the aponeurosis of the external oblique. Another landmark that you need to know is the inguinal triangle. Inguinal triangle is the triangular region of the deep part of the anterior abdominal wall. It is a weak area where direct hernia can occur. Inguinal triangle, or so-called Hasselbalch's triangle, is bounded medially by the rectus abdominis, inferiorly by inguinal ligament, and laterally by inferior epigastric vessels. Presence of the conjoint tendon and the reflected inguinal ligament directly posterior to the superficial inguinal ring also play an important role in counteracting the weakness in the inguinal area. The superior boundary or the roof of the inguinal canal is formed by the arched fibers of the internal oblique and transversus abdominis muscles, as well as the transversalis fascia. The floor is formed by a combination of the inguinal and lacunar ligaments. The anterior boundary of the inguinal canal is formed by the aponeurosis of the external oblique muscle and strengthened laterally by the internal oblique muscle. The posterior wall is formed laterally by transversalis fascia and medially by the conjoint tendon. In female, the main structures that transmit through the inguinal canal include round ligament of uterus, ilioinguinal nerve, and genital branch of genitofemoral nerve. In male, the inguinal canal contains the spermatic cord and ilioinguinal nerve. The spermatic cord contains structures such as testicular vessels, genital branch of genitofemoral nerve, and vas deferens. An inguinal hernia is a protrusion or passage of a peritoneal sac with or without abdominal contents through the abdominal wall in the groin, Inguinal hernia is classified as either direct or indirect inguinal hernia. Direct inguinal hernia occurs due to the weakness of the abdominal wall. For this type of hernia, the hernia sac protrudes through a weak point in the fascia of the abdominal wall without entering the deep inguinal ring. The neck of the hernia sac is medial to the inferior epigastric vessels and within the Hasselbeck's or inguinal triangle. Direct inguinal hernia is a less common type of hernia, is age-related, and usually affects men over age of 40. Indirect inguinal hernia is the most common type of inguinal hernia and is located lateral to the inguinal triangle. It is congenital, which means it occurs due to the patency of processus vaginalis connecting peritoneal cavity of the abdomen and that of the scrotum or labia majora. The indirect inguinal hernia enters the inguinal canal through the deep inguinal ring. Since the deep inguinal ring lies lateral to the inferior epigastric vessels, the neck of the hernia sac protrudes through the lateral inguinal fossa, shifting these vessels medially. Indirect inguinal hernia emerges at the superficial inguinal ring and descends to the scrotum, where it is covered by the external spermatic fascia, superficial fascia, and the skin. The hernia sac may be strangulated and the blood supply compromised at the deep inguinal ring. Another type of hernia is the femoral hernia, which is located inferior and lateral to the inguinal ligament. I hope you have answered the quiz that I've uploaded earlier in PDF version. Now let's check the answer. Question number 1. Identify the labeled structures. A. Campus fascia. B. Scarpa's fascia. C. Rectus sheath. D. External oblique or external oblique muscle. E. Tendinous intersection. F. Rectus abdominis muscle or rectus abdominis. And G. Pyramidalis or pyramidalis muscle. Second question. Identify the nerves in this picture. A. Iliohypogastric nerve. B. Ilioinguinal nerve. C. Lateral femoral cutaneous nerve. D. Genitofemoral nerve. E. Femoral nerve. And F. The obturator nerve. I don't have special mnemonic to memorize the nerves, but there are a few tips to help you to memorize them. For example, iliohypogastric and ilioinguinal. The word hypogastric starts with H and inguinal starts with I. So, in alphabetical order, iliohypogastric comes before or superior to the ilioinguinal. You can also identify them by understanding the meaning of their names. Psoas muscle can also be used as a landmark for you to identify certain nerves. For example, genital femoral nerve is easily identified because it pierces the psoas muscle. For femoral nerve, the location is lateral to the psoas muscle. And finally, the obturator nerve is located medial to the psoas muscle. Subcostal nerve is not labeled in this picture. Subcostal nerve is superior to the iliohypogastric and runs along the lower border of the 12th rib. That's all for the first part of Abdomen lecture series. Thank you.